Hello, this is Chadi Alraies from Denver, Colorado, CVI 2019. With me is Qais Radaideh. He is a research fellow at Midwest Cardiovascular Research Foundation, and he has done a lot of work in peripheral intervention. Welcome, Qais.
Yeah, thank you. Hi, Dr. Shadi. How are you?
So you are doing, you presented a case today as a challenging case.
Yeah.
Can you walk us through it?
Absolutely.
In terms of limb salvage?
Absolutely. So, 78-year-old gentleman with the classic risk factors, diabetic, coronary artery disease, peripheral artery disease. So he presents to our lab with the ulcer over his left heel that's not healing. RB class 5. So he was taken to the angio suite, and from his baseline angio from an antegrade approach showed severe disease in his distal SFA, almost a full CTO. He had prior stenting to the distal SFA that was totally occluded, the vessel reconstituted distally to a single runoff at the AT. At this point, the patient has really severe disease. So we opted to revascularize from a contralateral antegrade. We upgraded the sheath for a 7 French sheath, and crossing antegradely was extremely difficult, and so we almost attempted for 60 minutes to try. Despite wire escalation, we were unsuccessful. Now the patient has only a single runoff that's diseased, so but it was the last resort, so we decided to do a pedal access under ultrasound guidance. Of course, heparin and nitro were given, and crossing was actually successful from the retrograde approach. And at this point, we decided to use IVUS for better lumen estimation. And we know that from history and literature that actually angiography is suboptimal to estimate calcium, thrombus burden, and to have a proper lumen estimate for the diameter.
Right.
So surprisingly, angio has estimated the diameter to be around 2.7 millimeter of the AT. On IVUS it was around 4 millimeter measured from internal elastic to internal elastic lamina, 6 millimeter from external to external. So at this point we opted to size the balloon. We used a coronary balloon, a 4 millimeter balloon, to dilate the area of stenosis at the proximal AT. We successfully did that, and as we also achieved the crossing, we did some dilation from the antegrade approach with a 6 by 100 6 millimeter balloon. Unfortunately, the distal pop has developed a type C dissection. Of course, the patient has a single runoff, so we decided that the patient would require stenting. We did use a stent from the retrograde approach sized as a 4 millimeter Zions DES stent. We dilated that up to a 20-22 atmospheric pressure. What also is interesting in the infrapopliteal disease is the medial fibrotic and calcific nature of the disease there. It's kind of different than what we see in the above the knee, which is mostly calcified plaque. Here it's more fibrotic in nature. So we had to require really high pressures of dilation. Another interesting finding is the IVUS detected a dissection as we did this high pressure of dilation.
So angiography didn't show it.
It didn't show that, yeah. So we did use the DES stents and the distal AT. We had to stent the distal pop with the Illuvia stent, and really the flow was excellent to the dorsalis pedis. Of course, hemostasis was achieved with manual pressure, and we did an antegrade injection of contrast. Integrity was maintained for the dorsalis pedis. A few learning points in this case that, of course, angio is not the best option to estimate diameters for vessels, especially in below the knee where the vessels are really tight and diseased. Another thing, IVUS allowed us to see this fibrotic nature, and we were more aggressive in dilation. Another point is pedal access. I know the patient has only a single runoff, but it's a very important skill for the endovascular specialist. It saves a limb, really. And finally, we are running a study at our foundation. We had a hypothesis that undersizing is probably the reason for the failure for the prior below the knee trials with either stenting or plain balloon angioplasty. So we are running an eye dissection study that uses IVUS at baseline, IVUS after the intervention, and the operator has the chance to decide whether it's atherectomy or just angioplasty balloon. And we do have some preliminary results which will be presented in the next conference.
Nice.
Thank you.
So based on what you're saying, you recommend routine IVUS for below-knee?
Yes, because in severely diseased cases, I mean, of course, a case-by-case approach, and IVUS, we've seen we properly sized the vessel with IVUS. Absolutely, it's almost a 30% discrepancy.
Yeah.
Yes.
That's great. I mean, thanks again, Qais, for presenting this interesting case and the insight on the role of IVUS for below-knee intervention. This is Chadi Alraies from CVI 2019, Durban, Colorado. Thank you.
Thanks.